Good afternoon and welcome to RCI's Navshikar channel. I welcome all our viewers to our show today. Our topic of discussion for today is gait analysis and gait deviation in prosthetics. And to discuss with us on this topic today, we have our experts, Dr. Gautam Jain, who is Head of Clinical Services, and Dr. Abhinav Tripathi, who is a manager for training and research. Welcome, sir, to our show today.
Thank you.
Now, before we begin our session today, I would like to give a brief introduction on what exactly prosthesis means. It's basically an artificial extension to replace a missing body part. Now, these body parts can be lost by injury or they could be missing by birth. And gait analysis is basically the movement of lower limbs in a body. And this basically today our discussion will be about the gait analysis of people with deformities, people with injuries, etc. Now, I'll request our viewers to please call us on these numbers if they have any queries relating to this discussion today. Our numbers are, the toll-free number is 1800111208, the phone number is 265111613, and the fax number is 265110609. I would like now to begin our session today. So, would you begin first? So, if you could just tell us in layman's terms what exactly is prosthetics and gait analysis, just a brief introduction about it.
Prosthetic as a definition is, in simple language, is the replacement of an existing extremity. It can be a lower limb, it can be an upper limb. It's basically a replacement of any extremity is an artificial limb. It's called the prosthesis. The field is called the prosthetics and the appliance is called the prosthesis.
Okay.
So before we actually go into the topic, we would like to talk about what is normal human locomotion. Before we talk about the artificial locomotion, we would like to talk about the normal human locomotion. What is normal human locomotion? It is basically a rhythmic movement of extremities, right? Like to progress the gait in forward movement. We are talking about the center of gravity. The progression of center of gravity with respect to the lower extremity and the trunk is called the normal human locomotion. So there are different definitions which we normally frequently use terms in this normal human locomotion. They are basically the gait cycle, the stance phase and the swing phase. If you look at the slide, we have different definitions. As the gait cycle is the number of steps, like heel strike of one extremity to the heel strike of the same extremity is called the gait cycle. The stance phase is the weight bearing phase is called the stance phase. That is the heel strike. It starts at the heel strike of one extremity and ends at the just before the limb is taken off from the ground. It is the stance phase. And the final is the swing phase of the normal extremity. That is, it starts when as soon as the extremity leaves the ground, it starts to swing. It's called the swing phase of the normal person. Means it's called the swing phase of the gait cycle. Basically, it's, if you see the slide again, we have phases of gait cycle. We have stance phase and we have swing phase. The weight bearing, as you can see the slide, the weight bearing phase is called the stance phase and the swing phase when it is not touching the ground. There are subdivisions of gait cycle and subdivisions of stance phase. Mr. Abhinav would like to focus on the subdivisions of stance phase. Yes.
Yeah, the stance phase basically when heel strikes, it has basically four stages. So when heel strikes the ground and foot goes in the foot flat position and then heel off and then push off. So these are the four phases of stance phase. And then subdivision of swing phase. The swing phase has acceleration, mid swing and deceleration. So after deceleration again the heel strikes. So at the time of heel strike this cycle completes.
Yes, heel strike is basically as soon as the heel lands on the ground is the heel strike. Then we have the foot flat. Immediately after heel strike the foot goes flat. That is the foot flat state. Then it comes to mid stance. When the total body is vertical, one limb is flat on the ground and the other one is in swing phase. And then it is push off. That is, it leaves the ground. So that is the push off stage of the stance phase. Then we come to the subdivisions of swing phase. That starts, as I said earlier, was as soon as the the stance phase goes off, it leaves the ground, it goes into a swing phase. It first goes acceleration, then it goes to mid swing, and then it is before heel strike it stops. So it's called deceleration phase of a gait cycle. That is subdivisions of swing phase.
So how would you define double support?
Okay, double support is a phase when at same stage both the feet are contacting the ground.
Okay.
That means it starts just before heel strike of one extremity and just before the swing starts of the other extremity. In overall phase is around 11% of the gait cycle. That is what we call as the double support of the gait cycle. There are different time durations involved in the gait cycle. That is, it's got a stance phase, swing phase, and a double support phase. As you can see the slide, you have 60% of the gait cycle is the stance phase. You have swing phase of the 40%, and the double support is 11%. But we have to remember this: as we go faster, as the person goes faster, the double support phase reduces, and the swing phase increases.
Okay.
Because it's going faster, the swing phase means the double support is, if the person is running, is hardly contacting the ground.
So with increase in speed, the swing phase is increasing.
Yes.
Okay.
And the double support is
Decreasing.
totally decreasing. If it is running, the double support is totally eliminated.
Okay.
And the running phase, basically the double support is minimum to 0.
Okay.
I mean, because there is no contact of both the extremity at a time on ground. So in running position, the double support is minimum, and fast walking it is less, and in normal walking it is 11%.
Okay. If you could just show our viewers the gait cycle clipping on the presentation, please.
So this is a complete gait cycle clipping. It starts with the initial contact of the right limb. If you can see the black section is black section, that is this section, and it ends when the heel strike of the same extremity takes place. Okay, in between we have double support, in between we have swing phase, in between we have stance phase. So for completing one complete gait cycle, you have stance phase of one extremity, swing phase of one extremity, and double support of extremity, and the same thing for the other extremity. So we have double support, we have swing phase, we have deceleration, acceleration, or part of this gait deviations only. If you can see, heel strike of one extremity and ending to heel strike of the same extremity is a description of a complete gait cycle.
So the cycle will be complete when we start in the same way and when we end with the same way.
Yes, that is the complete.
In a gait cycle, we have 2 double supports and 1 stance phase and 1 swing phase.
Okay.
So in the beginning there is 1 double support, then comes a stance phase, and then at the end there is a double support.
Okay.
There are certain characteristics
Normal
of
gait.
normal gait. Abhinav, would you like to?
Yeah, the characteristic of normal gait is a vertical displacement and lateral displacement of the center of gravity, width of the walking base, horizontal dip of the pelvis, flexion of knee during the stance phase, and the cadence. Now we'll go one by one for this.
These are the basically characteristics of a normal walking gait cycle. We are right now talking about a normal person with a normal gait cycle.
And a normal gait is with people who have no deformities, or injuries with themselves.
Yes, exactly like that. So we have the vertical displacement of center of gravity. As we progress forward, at the time of heel strike, the center of gravity moves up, and at of foot flat and double support, it goes down. So we are looking for, what we are talking about is the movement of center of gravity forward. That is the gait cycle.
Okay.
So the normal gait cycle, there is a upward and downward movement of center of gravity. So at the time of mid stance, peak of mid stance, the center of gravity is at highest point, and at the time of double support, it comes at the lowest point. So normally the center of gravity moves up and down in a rhythmic manner.
And the range is not exceeding 2 inches.
Okay.
Within that 2 inches, a normal person should be displacing the center of gravity.
Okay. So that means if a person is displacing center of gravity within 2 inches, then
It's
that's
a
normal gait.
Normal gait. So that's what we will try to replicate in the prosthetic gait.
Okay.
The second characteristics was lateral displacement of pelvis. So as we go for heel strike, there is a lateral movement of the pelvis which takes place from side to side, which again it is within the 2 inches parameter.
Okay.
As we go for heel strike, the pelvis moves towards the limb which is going on heel strike, and as we go on the other support, it moves laterally onto the other side, which is the lateral displacement of pelvis we are talking about, which is again within 2 inches of frame.
So that means if it's less than 2 inches or more than 2 inches, how do we define when it's not normal?
Average normal person should not deviate more than 2 inches.
So
If
it should
is
neither
less,
exceed nor.
it should not be more than that.
Okay, so it can be less than that.
It
It's
can be
fine.
less than that is fine.
Okay.
Then we have the width of the walking base. If you can see the slide, it clearly shows the heel strike, the peak point, and the heel strike of the other peak point. The two extremities, the distance between the two, it's the width of the walking base. The wider we go, more deviation. We call it as it's a normal, not a normal gait, but it
Okay.
depends on the human skeleton.
Okay.
It's nothing abnormal about it, but it depends on the human skeleton. The same parameter we want to copy on the prosthetic gait. That it should not be very wide. It should be a narrow walking base.
So approximately how much distance should be there between the two?
6 to 8 inches is the normal
6 to 8
distance.
inches. So that means 2 inches for the height and 6 to
2
8
inches for the center of gravity,
Center of gravity.
and 6 to 8 inches distance
width.
between the foot
Okay.
of heel strike if the patient is walking.
Okay.
Then we have another character is horizontal dip. Means we have talked about the vertical dip, we have talked about the
Lateral.
lateral dip, and then we have the horizontal tilt of the
Pelvis.
Yes, Abhinav.
So in this, what happens when the patient, when a person take weight on a limb, the pelvis drops on that side, and the other side of the pelvis goes up little bit to clear the ground. So every time at the time of heel strike, pelvis of the weight bearing side drops down, and the contralateral side goes up, and the same thing reciprocates in both sides.
It is more of a angular change now.
Okay.
We were earlier talking about the lateral displacements. Now this is more of an angular change what we are talking about, which is approximately 5 degrees of the pelvic tilt. We are
Okay.
talking about in this particular phase of the gait cycle. This is a very important phase, that is the knee flexion during stance phase. It is called the
So
stance.
what is knee flexion?
The knee goes in slightly flexion. That means immediately after heel strike, to eliminate the vertical displacement of center of gravity more than 2 inches, the knee goes in flexion.
Okay.
So the overall distance from the heel and the center of gravity, which is supposed to go up immediately after heel strike, the knee goes in slightly flexion. So the distance reduces, and which has two major functions. One is to reduce the displacement, and one to give shock absorption immediately after heel strike. That is, we call it stance flex during knee flexion during stance phase. Means stance phase is the weight bearing phase. So at weight bearing phase, immediately after heel strike, the knee goes in slight flexion, which is around 20 degrees for a normal person.
Okay.
So basically, the two main features are like to absorb the shock at the time of heel strike, and the second is to reduce the actual length of the body to clear the ground. So that is for that knee goes in 20 degree of flexion, and subsequently hip and ankle goes in a particular angle of movement.
So that means if a knee is going in 20 degrees of flexion, then it's
It's a
perfectly normal gait.
Yes.
gait.
Okay.
Finally, it is not to displace the center of gravity for more than 2 inches.
Okay.
Then we have the cadence. Cadence, the simple definition is number of steps an individual takes in one step. That we call it as a cadence.
Okay.
A slow walker would be say around 70 steps in 1 minute, and a fast walker would be around 130 steps per minute. An average adult would be say around 90 steps per minute.
So it's
And
perfectly normal to walk between 70 steps and 130
130
steps.
steps.
per
If
minute.
somebody who is going for a morning jog, say something very fast walking, he would go for 130. And somebody who is in the market or going to the parking place, whatever, it's say around 70 degrees. And average speed is around 2.5 miles, which is somewhere close to 4.3 kilometers
Yeah.
an hour speed a normal person should be walking in.
So does the cadence vary from males and females also?
That's why we have the range.
Okay.
It depends on the individual. A female can be a fast walker and a male can be a slow walker. So why we are discussing all this is basically we want to replicate all this function onto the artificial side, if this is for a normal patient, and all these features we want to give to a patient who has lost his limb. So we are discussing the normal, after losing a limb, he should be having the same features.
So using prosthetics, we can still go on in the normal way.
We should go, so we must understand the normal way first, so that we can replicate this
By prosthetic.
by prosthetic devices to a normal gait cycle also.
Okay.
So once we know the normal pattern of walking, so we try to achieve the same thing when we fit an artificial limb to the patient. So we try to match these parameters with the prosthesis basically. So for that we do different changes in the prosthesis, we do different type of alignment in the prosthesis, and try to achieve as much as possible close to these parameters, because these are the parameters for the normal person.
And before we go into the actual gait deviation, our second phase of the discussion, basically we will be studying into 3 phases. That is heel contact of mid stance point, and mid swing, and then the swing phase. So gait analysis of the transfemoral amputee, that is basically an above knee amputee. Gait analysis, we will be studying the gait deviation in the same, and what are the causes and how to solve it, from which view to see it. We will be discussing gait analysis of transfemoral amputee.
A transfemoral amputee is one who's got a problem above the knee.
Above the knee.
Okay.
The complete loss of limb from above the knee is transfemoral. That is, the sectionized section of femur is amputated.
Okay.
So Abhinav, would you like to stress on this?
Yeah, the amputee gait analysis. The gait analysis we do for with the person using a prosthesis to match with the actual, the standard pattern of walking. So we observe all the things like the cadence of the amputee, and then the step length of the amputee, and the way the width of walking base, again the pelvic drip, what all we have discussed before. We all try to observe in the amputee's gait, and then try to achieve the same thing in the amputee's gait.
Basically, what we are trying to study is the alignment of the processes. As a normal study which we conducted is, it should not displace more than 2 inches, has a lateral angular change of 5 degrees, vertical dip of 2 inches. So same thing, if it is studied in deviation, how to correct it to give an amputee a normal gait. That's what we call as amputee gait.
So that means in order to correct the gait of a deformed person, we have to go through an amputee gait analysis, in which we first study the gait of a normal person, and then measure how the
how to
differences
rectify
are.
it, how to
rectify it with the gait,
and what is
with
the
prosthesis.
basically what is the problem with his gait, and match this gait deviation with the normal gait, person gait, and try what to do to solve this gait.
Find the corrective measures.
Yes.
All right.
So first among the group is the lateral trunk bending.
Okay.
If the trunk is bending more on the amputated side or the normal side, so why that is happening? Described as the amputee leans towards the amputee side. He is leaning more on the amputee side and less on the normal side. So if we see a person walking like that, he will have a dip on the amputee side, and
That could be towards the left or the right, both.
it's more on the amputee side.
Okay, and that is the left side.
If it is the left side,
Okay.
if it is the left amputee,
Okay.
and it is dipping more on the left side, then we call it as lateral trunk bending.
So the side on which the person's got the deformity or the
Artificial
injury.
The
Yes.
side
Is the
of
amputee
the
side.
limb on the side of the prosthesis, the side where the prosthesis is, that side patient, the tendency of patient to bend the body towards that side is basically lateral trunk bending. In
Okay.
common terms, we call it as a limping gait. Basically.
Okay.
So basically, we have to see which phase of the gait cycle we have to see this.
Okay.
It starts when the patient strikes the ground at heel strike, means initiation of stance phase. As the patient strikes the ground and goes into mid stance, he dips on the artificial side. If it is on the right side we are studying, so he strikes the right foot and he dips on the right side, so he gets a lateral trunk bending. And from which place to observe? It has to be observed from behind the patient. If we see it from behind the patient, we can see it clearly that he is dipping on the amputated side. Okay.
So that means if the person's bending towards the amputated side, then that means that's called lateral trunk bending.
Bending.
And that's not a normal gait.
That's not normal gait, but there are different causes, means why it is there.
So would you like to discuss
Yes.
the causes, please?
Yeah, there are various causes of lateral trunk bending. When patient walks, we can observe it from either from front or the back side of the amputee. And the causes could be the hip abductors. There are muscles who control the abduction of hip joint. So we need to assess at the time patient whether his abductor muscles are really weak, or is there any other reason for the bending. If the abductors are weak, we can guide patient for a particular exercise to develop, to strengthen the muscle and to avoid the lateral trunk bending. Then other reason is the abducted socket. Like socket is a part of prosthesis which it is a interface between the prosthesis and the limb, artificial limb. So it contains the stump, the residual limb. So the socket, if it is aligned with respect to prosthesis in abduction, like it is in angle away from the body, so that also causes a limping of the person.
And there are other reasons, like if when we design a socket is a part which comes in contact with the stump, and we design it in such a way ki there is a lot of lateral gapping in the socket. He is not getting sufficient support from the socket, then he will result in trunk bending. So we go back and rectify the socket. Then we have pain or discomfort. He is having the design which we have made, the prosthetist has made, it's not up to the standards. There is some problem in the socket, and he is having pain in the end of the socket or wherever he is having pain. So he will result in lateral trunk bending.
So whenever we have pain, we tend to bend towards that side of our body
Yes.
part.
So we see these points and go back and rectify these points. Like if it is gapping, we reduce the gapping. If it is pain, we find out where exactly it is a pain and eliminate the pain. If it is abduction, as he said, if there are weak muscles, so we ask him to go for therapy and strengthen the muscles. Or the alignment is wrong, so we go back again, do the correct alignment and bring him back to the normal gait cycle.
So that means we have to first observe the person with a deformity, and only then can we judge the causes and then the kind of deformity.
We need to find out
he
first what's happening first and what is the cause of it, and then rectify those cause to give him a normal gait.
Okay.
I mean, there could be three causes for any deviation. First is the physical status of the person, like the condition of his muscles and the body part. And the second could be the reason of prosthesis. I mean, the alignment of the prosthesis, whether the correct alignment according to the person. And the third could be the walking pattern of the person. That may be the pattern of the person he is used to walk. So we really need to assess. We need to check whether which is the reason for this deviation of gait. So accordingly, then we try to achieve the correction.
The second in the line is the wide walking base. As we were discussing earlier, there are certain 6 to 8 inches of distance as a normal person should be walking. But if it is a wide walking base, then the standard, then what we call it as wide walking base, also called as the abducted gait. He walks with the prosthesis sideways. Again, from where to observe? We have to observe from behind or front of the patient, because from there exactly we can see the load line, where exactly it is going, the normal away from the normal range. Then from how to observe, as I said, from behind the patient, and which phase again to observe. So this is the phase when it is going into swing phase. Swing phase means as he leaves the ground, the amputee, the prosthesis, as it leaves the ground, it goes from sideways. So it's a wide walking base.
So that means if a person's walking with his legs apart, wide apart, if the gap is more than 6 to 8 inches, then that's known as an abducted gait, and that's definitely not a normal
gait. So
Okay.
it is when it is a double support. So we measure the distance between the two, and it is wider than the normal.
Okay.
So it is a wide walking base.
So by measuring the range of the gap between the legs,
foot pieces, yes.
between the foot pieces,
Yes.
we determine it.
Then again causes.
The abducted gait, again there could be a prosthetic cause. Maybe patient is getting pain at the crotch area, the groin area of his body, from the medial part of the socket, the brim of the socket. So he will take the prosthesis in abduction to get some relief in that area. So he may walk in abducted gait because of the pain at that area. again the socket, if it is not aligned properly, then he will increase the base and to avoid the dip of the body towards the prosthetic side. And the one more reason, I mean, if the length of the prosthesis is more, to overcome the clearance, I mean, to clear the ground, he will walk with the abducted gait. And if the swing of the prosthesis is not proper, I mean, it is slow, or the knee joint friction is high, patient will walk with the abducted gait.
And the final reason is if he's scared, so we go for a wider walking base. He's scared of falling in a narrow, if the person is asked to walk in a narrow line or a narrow platform, we are also sometimes scared, so we go for a wider walking base. So if he's, after using an artificial limb, if he's scared of walking, he will have an abducted, that is a wide walking base for better stability. And the major one patient reason could be that the stump after surgery, it's in slight abduction, it's a deviation, and we have not accommodated that, the prosthetist has not accommodated that in the prosthesis. He will end up having a wide walking base.
So if there is a patient with a deformity, does he have to undergo some physiotherapist consultancy?
Ideally, yes, he should go initially before fitment, and after fitment also he should ideally go for physiotherapy exercises to eliminate all these deviations which we get because of his weak musculature or other reasons.
Okay, so that means to get a gait as normal as the other people, he has to go through consultancy of physiotherapists.
Yes.
And a lot of other trainings.
Yes.
If required, I mean, if he is having a physical deformity in his residual limb, then he will have to go to the therapy for eliminate that deformity. And if it is for his physical problem, then also for strengthening purpose, he can consult a therapist.
Because what's happened is after amputation, he has lost his or her muscles of natural function. So because of that, he may end up having deformity gait or deviated gait.
Okay, so till now we've discussed the phases of a gait cycle, we've discussed double support, we've discussed cadence, we've discussed these characteristics of a normal gait, and also the gaits that are not normal, that is the abducted gait, the lateral trunk bending, and the causes why it's caused. So now, keeping all this in mind, we'll continue our discussion after a short break. So see you after the break.
ऑटिज्म एक व्यापक विकासात्मक विकलांगता है जिसके लक्षण जीवन के प्रथम 3 वर्ष में ही दिखाई पड़ते हैं, जैसे असंगत खेल, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं, शाब्दिक संकेतों पर अभिव्यक्ति न देना।
देखो, ओपन योर आईज, ओपन करो, ओपन करके ओपन।
नियमित कार्यक्रम परिवर्तन का विरोध करना एवं अवलोकनीय शारीरिक उच्च स्तरीय या निम्न स्तरीय क्रियाकलाप। UNCRPD 2007 सेक्शन 1 ऑफ आर्टिकल 4 निशक्तता के क्षेत्र में कार्यरत प्रोफेशनल के प्रशिक्षण पर महत्व देता है। ऑटिज्म के क्षेत्र में सरकारी एवं गैर सरकारी संस्थाएं कार्यरत हैं जो भारतीय पुनर्वास परिषद द्वारा पंजीकृत हैं। सोसाइटी फॉर एडवांस स्टडी इन रिहैबिलिटेशन एक ऐसी ही गैर सरकारी संस्था है। कनिष्क 13 साल का एक ऑटिस्टिक बच्चा है जो इसी संस्था से प्रशिक्षण प्राप्त कर रहा है। असंगत क्रियाएं, कार्यकलापों में निरस्ता, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं जैसे बॉडी रॉकिंग और फिंगर रिगलिंग उसमें देखी जा सकती है। उसे मैचिंग और पेस्टिंग, पॉइंटिंग जैसी क्रियाएं सिखाई जाती हैं।
वेरी गुड। ग्लास, वेयर इज द ग्लास? ग्लास, वेरी। कप को टच करो जल्दी से, कप को। वेयर इज द कप? वेरी गुड। कप में क्या करता है कनिष्क? टी पीता है। चलो, ग्लास, वेयर इज द ग्लास? वेरी गुड. चलो बाउल किधर है? बाउल बाउल जल्दी से टच करो बाउल को. वेरी गुड. बाउल में क्या करता है कनीज?
तथा साथ ही साथ रोजमर्रा की आवश्यकताएं जैसे खाना, पीना, कपड़े पहनना, और व्यायाम संबंधी प्रशिक्षण दिया जाता है. ऑटिस्टिक बच्चों को भिन्न भिन्न प्रकार की कार्यविधियां उनके स्तर के अनुसार सिखाई जाती हैं. जैसे कुछ बच्चों के लिए कलरिंग विद इन वन एरिया, मैचिंग एंड आइडेंटिफिकेशन, फाइन मोटर स्किल्स, आई हैंड कोऑर्डिनेशन, concept of vegetables, fruits, body parts, कलर्स पर जोर दिया जाता है तथा कुछ को प्रश्न पढ़ के उत्तर देने में और रोजमर्रा की आवश्यकताओं को पूरा करने में सक्षम बनाया जाता है. इसके अलावा राइम्स, डांसिंग, सिंगिंग द्वारा लेजर एंड रिक्रिएशनल एक्टिविटीज में भाग लेने के लिए प्रोत्साहित किया जाता है. इन सभी कार्यकलापों एवं प्रशिक्षण का एकमात्र उद्देश्य उन्हें स्वनिर्भर बनाना है ताकि ये डगमगाते पांव सक्षम बन जीवन के एक एक पायदान पर दृढ़ता से आगे बढ़ें और अपनी मंजिल को पा लें. एक तारा टिमटिमाता, उसने आकाश को छू लिया. एक लौ जली कहीं, उसने अंधकार को मिटा दिया.
Welcome back after the break. Our topic of discussion today was gait analysis and gait deviations in prosthetics. And right now we were discussing the various kind of gait deviations that are present. The first that we discussed was lateral trunk bending. The second that we discussed was the abducted gait, and we discussed the causes also for those gaits. And now the third is circumduction. So could you please elaborate on circumduction?
Yes, circumduction is basically when the limb goes in a circular pattern. As you can see in the slide, it goes into a circular pattern. That means ideally it should go in a straight line, in an angular movement, but it goes in slight circumduction. So which phase of the gait cycle we have this deformity is when we start the swing phase of the gait cycle. As soon as the artificial limb leaves the ground, it goes in circumduction and then it strikes the ground again. That is the from where again to see? We see it from behind the patient or from front of the patient, where we can see the linear angular movement of the artificial side. So then again, how to observe? As I said, it is from front or back of this thing, from the amputee. But the major causes of circumductory gait, or the basic initial cause is the limb is too long, so he is not able to clear the ground, so it goes in slight circumduction. Second is if the alignment, again it all basically goes for alignment. If it is aligned slightly sideways, so instead of going straight, it goes in slightly circumduction. And again, this is the manual, it is a locked knee. In case if it is a locked knee in case of the processes which we have prescribed is a locked knee, he is not able to clear the ground straight, so it goes in slight circumduction. And again, if we make the socket is too short, so it ends up resulting in the gait going slightly into circumduction.
So that means any person who's having a slightly circular motion in gait is having a problem of circumduction,
which is not again a normal pattern of walking.
That's again a gait deviation.
Gait deviation.
Like there's a difference in earlier one and this deviation. Like the previous one was abducted gait. in which the prosthesis goes in abduction throughout the stage, throughout the phase. And this deviation, this circumduction, the prosthesis goes in a circular movement. In abducted is goes in a wide base and continuously throughout the phase. But in the circumduction, some circumductory gait, it goes in circular movement and then land up. The causes of both the deviation is almost similar, except the previous one. It has if the length of the prosthesis is more, then it the cause of
could cause by abducted gait also. It could be because of circumduction. It could result in circumduction also.
So one common cause that you've mentioned is the length of the prosthesis. So why can't we have a normal length? Why is it that the length is long?
Again, we are going to gait training now.
Okay.
So at the time of training, we come to know that the length is not normal, and he's having this deviation, and then we reduce the length and eliminate this deviation. That is why we are studying his gait, the amputee gait. We are discussing amputee gait, and we do amputee gait because of this reason. That we come to know that the process is too long, so we reduce this processes to a optimum height. So we are studying a deviation to bring it into normal cycle of the person, or the normal cycle of the person.
So would you like to say?
Yeah, after amputation, when a patient comes to a prosthetic setup for a limb fitment, at that time, immediately after amputation, of few months of amputation, he has some swelling in his residual limb. So when we fit a prosthesis, initially we keep length of the prosthesis little bit higher, because gradually the swelling of the stump reduces, and the fitting, the stump goes more inside the socket, and then total length of the limb, the prosthesis reduces. So, and if we are fitting a components and we cut it short, and after few days it becomes short, then there is no scope of increasing it within, and the scope is only for 1 centimeter. And for that purpose, we keep the length of the prosthesis higher. So gradually fit the length reduce. The stump shrinks, and then apparent length, the total length of the prosthesis reduces. Then we, at the time of training, we finalize the length.
So that means the length of the prosthesis is basically kept a little longer than normal, so that even if there are some adjustments to be made later on, they can be done.
Can be done, exactly. So basically, as we are discussing, is basically causes of all this gait deviation. Firstly, the patient cause. It can be a muscle weakness, muscle contraction, or any other surgical problem. Second is the fitment. The one socket which we fit the patient, it can be of a problem, giving problem to the patient, resulting in gait deviation. Third is the alignment. If we have not aligned the socket and the system in a particular manner, which should give a natural working pattern, which is not correct. And third is the foot position. As in the circumductory gait, the last reason is he is not able to clear the ground because the foot is in slight plantar flexion. So as he goes in mid swing, it strikes the floor, the level surface, and he is not able to clear the ground. So he results in circumductory
Having a
gait.
circular motion.
Yes, to
Okay.
clear the ground. The fourth in this group is vaulting. We know is pole vaulting. Say we have the pole, and the person is jumping over the stick. So the same happens in vaulting gait cycle. So from which phase to observe this? When he is in stance phase or swing phase, we observe this. And from where to observe? Now this gait is we observe from the side of the patient. All the previous one we from front or behind. This particular one from side of the patient.
So that means vaulting is the kind of gait deviation that is observed from the side of the patient,
Yes.
whereas the ones discussed before are either observed from back or from the front of the patient.
Basically, he lifts his normal side, and means we are talking about the center of gravity,
Okay.
2 inches,
Okay.
and he lifts it more than that.
Okay.
So if we see the patient walking, he will walk with raised center of gravity.
He raises his body up on the normal side to clear the grounds, and then he clears the ground with the prosthesis, and again the center of gravity comes down. Means the point was the vertical displacement of center of gravity. So in this gait deviation, we observe the center of gravity is raising too high. The graph we get is too big than the normal. So there are certain causes of this gait deviation also. And that is excessive length of the prosthesis. The length, if you see this length problem, it is causing up to now 3 gait deviations, like abducted gait, circumductory, and now again a vaulting. To clear the ground, what patient does is he raises his body up instead of abducting the prosthesis or the circumducting the prosthesis. So he raises his body up and clears the ground, and again the center of gravity comes to the normal point at the time of the prosthetic heel strike.
Basically, an above knee amputee, what he needs is, at the time of heel strike, the foot should be there, the artificial foot should be there to land. Okay, to get this, he does all this action if it is not normal. To get this, he does is maybe he does circumductory gait to get the foot at the time of heel strike. He does vaulting to get the foot, or he does his abducted gait. And we need to eliminate that. Some patients the circumductory gait, some will do vaulting, and some will do abducted gait. So we are basically trying to eliminate the deviations to get a normal gait cycle. It could also be caused, that vaulting could also be caused because of insufficient friction at the knee joint.
Okay, so that means if there is more than 2 inches of center of gravity,
Left.
then that causes vaulting.
Yes. So insufficient means again he wants to bring it forward, and it's not coming fast enough. So he does his vaulting over the normal side and bring it fast enough. Just before the heel strike, he wants the prosthesis to be there. So that is why this gait deviation is there. The fifth in the category is swing phase whip. Whip, as we know, is movement sideways, either left or right. There are 2 whips. We call it lateral whip, or we can have it as a medial whip. So again, which phase to observe this? Just before he starts the swing phase. Just before he starts his swing phase of the artificial side, he will either get the knee or the complete prosthesis moving medially, or he will get his complete prosthesis moving laterally. That is what, again, this particular one we see it from behind the prosthesis, so that we can see the angular movement of the complete prosthesis.
Only from behind or from the front as well?
Front also we can see. Front also we can see. We can see the movement of lateral or medial movement of the foot from behind, ideally from behind, but we can also observe it from front of the gait. So as other causes, this also has different reasons of gait. It could be cause of, basic cause, again we start with the amputee cause.
Yeah.
It is weak musculature. He is not able to control the prosthesis. So it is he's got a loose skin, and it
Okay.
is moving in either of the 2 directions.
Okay.
So basic, what he has to do is, he has to go to the physiotherapist and get his muscles tone up right. But if he's an old amputee, he is not able to do anything. He can go for an hip joint or an additional support to control the prosthesis from moving medially or laterally. So we have got a swing phase whip.
And the main reason, as you told, is the alignment. If the knee joint is aligned rotation either in a medial side, inner side, or outer side, then it causes a medial. I mean, if the joint is aligned in a medial rotation, then it will cause a lateral whip of the prosthesis, and then if it is aligned in lateral rotation, then it will cause a medial whip of the prosthesis. So we need to check whether it is a prosthetic cause, knee joint alignment is proper, or that is a amputee cause. I mean, whether the patient is having sufficient muscle strength or the musculature good.
Again, if it is having a short stump, then he doesn't have the power to control the prosthesis.
So what
again,
exactly is a stump?
stump is the remaining part after amputation.
Okay.
If it is a transfemoral, you have a femur bone, say around 33 inches. Between that is transfemoral. So we talk about stump length. Longer the stump, better control of the prosthesis. Shorter the stump, weak control of the prosthesis. It's about the lever arm. We study physics. We have hand pump having a long lever arm, better control. So same thing here. You have a long lever arm, a better control of the prosthesis. So he's having a short stump, he'll have a weak control over the prosthesis. It will go medially or laterally, resulting in medial or lateral whip of the complete prosthesis. Then other one is the foot going in rotation after heel strike. So immediately after heel strike, the foot goes in slight rotation, which is again not a normal function. So again we have is how to observe this. We observe not from behind or to the front, because what we are seeing is the toe movement. If this is the complete foot, we are seeing this movement. So it is ideally seen when we are seeing from the front of the of the patient.
So
And
that
it-
means the gait deviations that we discussed till now were till the knee, and this one is only towards the foot.
The foot.
Okay.
Means what is observed, means what we are seeing, we are talking about that. So one of the deviation is only at the foot, other deviation was at the knee, some deviation is complete processes. If the whole process is going circumdictory,
Okay.
the whole patient is going vertically vaulting. So this what we are only talking about the
Foot.
foot going in deviation immediately after heel strike. So it starts at immediately after when the prosthetic side is going into stance phase.
Okay.
As he lands, it goes into slight whip. So again we come to the causes of this. So the basic cause is the foot, the heel of the shoe, the artificial side is too stiff. He is not able to roll over comfortably over the artificial side, and it is resulting in the lateral whip.
Because there is a certain shock absorbing device, or in normal foot there is a feature of foot to absorb some shock caused by the impact of the heel on ground. So if that cushion is too hard, if the cushion of the heel is too hard, it may cause the lateral or medial whip, I mean this rotation of the foot. And for that too, we need to see whether the foot is the heel is too hard, or whether there is some other reason at the proximal side on the socket area.
So again, socket, as we talk about the whip, this also is, if he is having a weak musculature and he is not able to control, he may either have a whip during swing phase, or he will have immediately after heel strike, as he is not able to control from the socket, he has got a lateral whip. So prosthetic, we can solve it by shifting the weight line anteriorly. We are talking about alignment, we are talking about musculature. So this, we can solve this problem by shifting the weight line anteriorly, or by reducing the hardness of the heel cushioning.
Okay.
As it reduces the hardness of the heel cushioning, it will go in plantar flexion, and will not have deviation. It will take a natural stand.
And where do we observe this gait deviation or foot rotation?
We observe immediately after heel strike. That is, as he lands on the ground, he'll have this movement to be from the front first, and then we view it from the side view also, and check the weight line of the processes. If it is too behind and excessive time he is taking at the heel strike, so we need to shift the alignment anteriorly to get the rolling action right.
Okay.
So then that stage we observe this rotation.
Foot slap. Yeah, the same thing. I mean, the foot slap when person walk and when amputee walk with the prosthesis, and when he strikes, when he land his heel on the ground, immediately after landing, the foot goes on flat on the surface. So that causes a slap like a movement. So that we call as a foot slap, and we observe from the sideways. And it is observed, I mean, we can see this immediately after the heel strike. When patient strikes his heel, you can see whether the foot is normal or it is going excessive plantar flexion, I mean the movement towards the ground.
There is a certain degree at which, and at the time, it should move. It should not be too hard, too soft, sorry, and it should not be too hard also. There is a certain grade of heel cushioning has to be provided in the artificial foot. That depends on the patient weight, patient activity, his structure. Accordingly, we decide which softness of heel cushioning we have to give to the amputee. Okay, whatever may be the reason, at this particular amputee is having a foot slap. That means the grade which is given to the patient is on the softer side, and we need to increase it to a harder grade so that he is a rolling over. What we are working on is a rollover phase of the gait cycle to get the natural. Immediately after heel strike, it goes flat. Don't go. It should not go slap.
So that means the foot has to fall softly and comfortably on the ground.
Immediately
So
after
that's
heel
how
strike,
normal.
it should fall softly on the ground.
Okay.
It should not be hard. It's not going only. If it is not going, it will result in lateral rip.
Okay.
And if it is going too hard, it will result in foot slap. What we call it, foot slap. So again, in this case, as in the previous case, we shift the alignment anteriorly to get a rolling action smooth. In this case, we shift it posteriorly.
Okay.
We have alignment devices in the processes which allow us to shift the weight line anterior posterior. So we'll get an appropriate rolling action over all our processes to eliminate all the gait deviation.
Okay.
So that is what we have is a foot slap. It's supposed to be seen from the side view, because what we are seeing is a foot angulation we have to see it from a side, and by doing corrective actions we can eliminate foot slap and resulting in a natural walking pattern.
So that means after vaulting, foot slap is another gait deviation which is observed from the side.
So at the time of selection of foot for an amputee, we need to check the activity of the patient and to select the proper stiffness of the heel cushion. If it is too hard, it will result in the rotation of the foot after strike, and if it is too soft for the person according to his weight and activity, then it will result in the foot slap of deviation of the gait. So when we assess a patient, I mean a prosthetist assess a patient for prosthetic fitment, he assess his activity, weight and other parameters, and then he see which type of foot he is
Ideal appropriate
for the patient.
and which cushioning of the ankle should be given to the patient to get the right. There are charts available, but some patients it can vary. So we study this gait deviation and give him an appropriate combination so that he gets a natural walking pattern.
So that means it's very necessary to observe the whole gait of a person before providing him with any kind of prosthesis and observing exactly
Yes.
what he needs.
Exactly. So basically again we start from the same point. We first have the amputee cause, we have the socket cause, we have the alignment cause, and one is the habit of the amputee. If he's
Okay.
using a certain processes which is not aligned properly for a very long duration, he results in a bad gait pattern, and eliminating that takes time, training. So we need to develop his muscles, we need to check his socket fitting, we need to check his alignment, and then finally give him training to achieve that proper gait alignment. So the another category in this is uneven heel rise. That means as a normal person when we walk, we have a certain heel rise of both the extremity. If an amputee has this, it's more than the normal. Normal is say around 25 to 30 degrees. Normal gait cycle, the knee flexes and goes extension. And if he's having more than that, it's going up and then coming, going up and then coming, which is not a natural walking pattern. So it has got a reasons for this. And from where to observe is, as we are seeing the knee angle, it has to be observed from this side of the patient. And at which phase of the gait cycle, again we see is before he starts the swing phase, because this is swing part of the gait cycle. So at swing phase of the prosthetic side, we have to observe this, and the major cause of this is we have as a natural person we have muscles to control the knee, that it should not go fast, it should not go slow. So this particular amputee should have some sort of friction device at the knee which controls the swing at the appropriate speed. But if that friction is too less and it's a free knee option, then resulting in excessive heel rise and coming forward, excessive heel rise and coming forward of that gait deviation. So to eliminate, again we increase the friction, or we give some device like a pneumatic cylinder or a hydraulic cylinder which brings it forward in a very smooth pattern, similar pattern of his natural knee, so that if the person is observing him from the side or from the front, he doesn't see any deviation and he walks like a natural person.
Okay. So would you like to discuss the causes of the heel rise?
Heel rise, the main cause, as you said, if you are using a particular knee joint, we need to check whether the axis, I mean the friction of the knee joint is correct. If the axis or the friction at knee axis is not correct, I mean it is a free knee joint, the movement of the flexion of knee will occur very rapidly, and that will cause the heel rise. If the knee is moving too fast in a movement, I mean it is flexing too fast, it will cause the heel rise, a rapid heel rise, and that will seen from the side, and that will be of course uneven from the normal side. And similarly the second cause,
Second cause is if it doesn't have a pneumatic or a swing phase device, like we have door closers. We push the door, it comes automatically, it closes. So if he doesn't have any swing phase device, so he has to wait for the swing to come forward because of the momentum, which is like if we have conventional system, this is one of the major observation seen on the patient using artificial system without any friction or without any swing phase device. He'll have to wait for the swing to come forward, which will result in reducing his speed of walking. So he'll have to wait, it goes up, he waits for the heel strike to come forward, again it goes up, he waits for this. So if you have the right amount of friction with the knee joint, and if you have the right amount the cylinder fitted at the knee joint, which allows him to bring the prosthesis. Again we come back to our original story, what an amputee wants. He wants the system to be there at the time of heel strike. If it is not there, he will fall. So all amputees and all professionals work on these lines only, that the system should be there at the time of heel strike. He should not be thinking that the system is reached or not reached. He should not be observing that if the system is reached or not reached. So if we have the right amount of friction and if we have right amount of cylinder, he will have a very natural walking pattern, and the heel rise will reduce because he will have resistance to have the heel rise reduced.
So that means the right amount of friction and the right amount of cylinder will result in a normal heel rise,
Yes.
and not an uneven heel rise.
Yes.
That is a gait deviation.
Yes.
And again, there is one more reason for it. If a patient is having a low confidence level, a patient is a little bit scared of walking, and he has very low motivation to walk, what he will do, he'll forcefully flex his hip joint, the hip joint, natural hip joint on prosthetic side, to move the prosthesis faster forward, so that when he moves forward, the prosthesis is the, as you said, prosthesis should be there to take weight, and again he will move normal limb faster to land on the ground and transfer weight on the normal side. So that also is a reason.
And
for
resulting in, if you push it faster, this will go back faster. So that means it will go higher faster, resulting in again uneven heel rise of the natural side, which is again not a natural reason of style of walking.
Okay. So you just mentioned that the low confidence level of a patient can be a cause for uneven heel rise,
Yes.
or even other deformities. So does a patient also need psychologists for consulting?
Some of the patients, like immediately after amputation, if a young amputee is there, he feels that his whole life is gone, the limb is gone, he is not able to walk. So initially, if he is not given, not all the patients, but some of the patients, if not given proper psychological treatment, counseling, that okay, this is okay, the life, at least the life is saved, only that part has been removed, but there are devices available which will give you a good swing. So initially, immediately, it's not natural to wear an artificial system.
Okay.
So we'll have to be trained first, and with the training, that's why we are studying all this Gait.
I mean, there is a less awareness about this artificial limbs in the patients. Normally, common man doesn't know what is artificial limb and what it is used for. I mean, they haven't seen. But after a normal person goes this trauma, more than a physical, there is a psychological trauma. So he has a mindset: I cannot walk in a life, and it will be difficult to walk. But when we fit a prosthesis, there is a resistance in his mind, and he doesn't accept the prosthesis, and he does not think whether he will be, I mean, he is in doubt whether he will be able to walk or not, and that reduces his level of confidence. So,
And as a natural, this thing, it's our body is not designed for an artificial weight transfer. We have done studies on this, how the weight transfer takes place, but it is an artificial weight transfer. So initially it will be very uncomfortable. So he feels his whole life it is going to be uncomfortable, and he is not accepting that it's going to be uncomfortable, and he doesn't want to walk. And as he doesn't want to walk, he walks with a lethargic gait, or he doesn't want to spend time on the artificial side to learn that okay, I can walk. So the range of patients varies. Some patients straight away, okay, artificial gone, we know the artificial limbs are available, and let's go and get it fitted, and with training I'll be okay. Some patients, because of their physical weakness or other problems, he is not able to walk properly.
So that means it's very important for the patients to develop confidence level that even if they have a limb problem or a deformity, along with the prosthesis help, they can definitely lead a normal lifestyle and also have a normal gait, even with the prosthesis and even with the deformity that they have. So till now we have discussed about the various types of gait deviations. We'll continue with our discussion, but now it's a time for short break. So we'll see you after a short break.
The chief handicap of the blindness is not blindness, but the attitude of seeing people towards them. आइए जानने और समझने की कोशिश करते हैं कि बधिरांधता यानी डेफ ब्लाइंडनेस क्या है। बधिरांधता एक स्थिति है जिसमें दृष्टिहीनता एवं सुनने की शक्ति में कमी आती है तथा जिससे विचारों के आदान प्रदान और रोजमर्रा की आवश्यकताओं की पूर्ति में समस्या उत्पन्न होती है। बलराम एक 9 साल का बधिरांध बच्चा है। वो एक प्री मैच्योर बच्चा है जिसका शारीरिक विकास उसकी आयु के अनुरूप नहीं हुआ था। वो एक निम्न वर्गीय श्रेणी से संबंध रखता है तथा 5 साल से लगातार नेशनल एसोसिएशन फॉर ब्लाइंड दिल्ली के प्रशिक्षण कार्यक्रम से संलग्न है। इन 5 सालों के अंतर्गत उसे रोजमर्रा के कामों में, हलन चलन में, उसकी शैक्षणिक जरूरतों के अनुसार संप्रेषण द्वारा प्रशिक्षण दिया गया है जिससे वो इन सब क्रियाओं में स्वावलंबी बन सके। बलराम बिना किसी सहायता के चाकू से फलों को काट सकता है। उनके छिलकों को कूड़ेदान में डाल सकता है। अपने बर्तनों को खुद साफ कर सकता है। उन्हें सही जगह पर रख सकता है। सही बर्तनों का चयन करके खुद खाना खाता है। एवं पानी की बोतल निकालकर पानी भी पीता है। इन सभी क्रियाओं में वो टेक्चुअल साइन लैंग्वेज से निर्देशों को ग्रहण करता है और अपने भावों को व्यक्त करता है। टेलर फ्रेम और ब्रेलर द्वारा गणित, पठन लेखन में भी प्रशिक्षण प्राप्त कर रहा है। सभी बच्चों की तरह उसका भी एक मनपसंद खेल है। उसे सेल फोन को अपने कानों पर लगाकर उसका कंपन महसूस करना अच्छा लगता है। कहा जाता है, वॉकिंग विद अ फ्रेंड इन डार्क इज बेटर देन वॉकिंग अलोन इन लाइट। कहने का तात्पर्य है कि वो लॉन्ग केन ट्रेवल, टैक्टाइल पाथ, ट्रेलिंग और लैंडमार्क्स द्वारा हलन चलन में भी सक्षम है और व्यायाम संबंधी क्रियाएं जैसे ट्रेडमिल, स्टैटिक साइकिल का स्वचालन भी कर सकता है। कहा गया है, द बेस्ट एंड मोस्ट ब्यूटीफुल थिंग्स इन द वर्ल्ड cannot be seen or even touched. They must be felt with the heart.
Welcome back after the break. Till now we were discussing about the gait deviations and the gait analysis in prosthetics. And until now we've discussed the various types of gait deviations. For example, the lateral trunk bending, the vaulting, we've discussed abducting, we've discussed circumduction, we've discussed about swing phase with foot rotation, foot slap, and uneven heel rise. Now we'll continue further with other types of gait deviations. Sir, would you please tell us about some other gait deviation?
Yes, the other ones in this line is the terminal impact. The terminal impact is the heel strike of the swing. The prosthetic strikes immediately after heel strike. There is a sound which is heard at the knee level. That is called the terminal impact. As you can see the slide, the sound comes from the knee joint immediately after the swing is complete.
Terminal, when amputee is walking with the prosthesis and at the end of the swing phase and just before the landing on the ground of prosthesis, there is a sound comes from the prosthesis that we call as the terminal impact. It is very clearly heard by the others, and it is very like a uncomfortable sound for a amputee, because he feels like it reduces his confidence. He feels like other will know I am using artificial limb.
Basically, we are studying this gait deviation is to bring him back to the normal life, and nobody carries a banner that's saying that I am wearing an artificial limb. So he doesn't want to know, and we also doesn't want others to know that he is wearing an artificial limb. So if he is walking in public, wearing his complete dress, and he is having this terminal, every swing it comes, so he becomes conscious, and others becomes conscious that he is having some problems which we don't want to disclose.
I mean, it is like a metallic or wooden sound at the time of strike. I mean, at every step. So that becomes very clearly noticeable, and there are certain reasons for this deviation.
Basically, we firstly see it from the side, because as we are seeing the angular of the knee joint, we cannot see it from the front. We see it from the side of the amputee walking. And at which phase we want to observe? It is at the end of the swing phase. That is, as soon as it ends and it goes into a stance phase, we hear this sound. And there are many causes of this terminal impact. The first major cause is insufficient friction at the knee joint. The insufficient friction also causes excessive heel rise. But if he is a strong amputee and has got a strong stump, so he kicks it forward faster, and the friction at the knee joint is not sufficient, so he'll end up having a terminal impact. Or he is not having sufficient bumpers at the extension stage. They are supposed to be extension bumpers. Bumpers means which absorbs the terminal sound. They are basically cushions, which stops this terminal impact. If he is not having, or they have been damaged or destroyed or not sufficiently adjusted, he'll have a result in terminal impact.
So that means we're supposed to have cushions also in the prosthesis so as to absorb the sound and not have a terminal impact.
Yes. And then the third reason, if he's using a swing phase device, and the swing phase device have got adjustment of swing as well as stance, or adjustment of speed, and to control the terminal impact. If the extension bumper, what we call, is not adjusted properly, will result in the terminal impact.
Basically, we need to reduce the speed of the limb. So if the friction is less, the limb will come fast and it will create an impact at the end of the swing. So we increase the knee friction, so the prosthesis in swing phase, it comes slowly forward and it lands very smoothly. And if the friction is very less, the swing will be very fast, and it will cause the impact on.
And if we go back to our initial slide saying of the swing phase, acceleration, mid swing, and deceleration. Deceleration means stopping, as he said. So it should slowly go in extension, and if it doesn't go in slowly, it goes fast, results in the terminal impact of the artificial limb, which we want to eliminate. And another in this line is uneven step length. As a natural person, we have a step length. One limb goes in heel strike, then the second, and then the third, and the distance between the two has to be same. That means if heel strike of one and the heel strike of the other one should be same as the heel strike of the other one to the heel strike of this one. So if that is uneven, not same, that what we call is uneven step length. As we see from the side, the amputee, the prosthetic leg and the sound leg should have the same distance. The traveling distance should be same, and if it is not same, it will result in uneven step length. And there are basic many causes of this step length. Abhinav?
What patient does is he moves the prosthesis too much forward and then normal leg up to the prosthesis, and that causes the uneven step length. I mean, that is because of the less confidence in the person using the prosthesis. If he is having less confidence and he is scared of moving his normal limb forward of the prosthesis because of the fear of falling, he may have fear of knee may get buckle, it means sudden flexion of knee, and he may fall. So because of that, what he does, he moves the prosthesis as much as forward and the normal limb up to that prosthesis. In the same way he walks, so that causes the
he is basically not able to overcome the prosthetic side with the sound side, because he has already taken a longer step length because of his fear on this artificial side.
So can this fear be overcome?
By exercise, yes. With usage, yes. If he uses the processes and we train him, okay, no, step length should be reduced, and with training, because he's not able to see, we have to guide him. So if we ask him to reduce, then again we come back to the patient cause. If he's having flexion contracture, he's already having tightness and he's having flexion contracture, and this flexion contracture is not accommodated in the system, it will result in a longer step length on the artificial side. So if we accommodate that flexion contracture in the artificial leg, he will not have this deviation during gait cycle.
So that means it's very important for the patient to have more practice, more exercises, and more practice basically walking with the prosthesis, so that he can have an even step length while walking,
and resulting in a natural walking pattern. We are all aiming for giving him a natural walking pattern, and by finding these causes, we eliminate one by one and give him again a natural. If we again, same problem could result in different deviations, like we were talking about insufficient flexion. So it caused too much heel rise, it caused terminal impact, and it could also cause uneven step length. He wants to end there, but there is no friction, it goes further ahead and resulting in a longer step length.
Another reason was the length of the prosthesis.
Yes, exactly. Again, we come back to another reason, that is exaggerated lordosis. Lordosis is a spinal deformity where excessive extension of the trunk takes place. If you can see the slide, clearly see the slide, lordosis is a C-shaped curve of the spine if viewed from the lateral side. So if you see the slide, he is having excessive lordosis, means the spinal curvature is exaggerated, means not a normal
the lower spinal curvature, it increases because of reason. For socket, if you are taking socket, for instance, if socket is not proper fitting and there is a gap in front, so the stem, this residual part, it moves forward, and to keep his center of gravity at position and to take weight on the socket, he takes his body back, so he increases the lower spine lordosis, the curvature increases. And if he is having a contracture like a fixed deformity at hip joint, so that also may create the lordosis.
Basically, we need to see this at the stance phase of the gait cycle. At mid stance, he should be standing straight, but he stands with a curvature to stabilize. Basically, he needs to stabilize the knee joint. If he doesn't stabilize the knee joint, it will result in buckling of the knee joint. So what he does is, he does these trick movements because of the problem in either the stump, that is the patient cause, either the socket or the alignment, which we need to find out exact cause. And when to see which view is the best view to see this is the side view, because we have to see the C-shaped curvature of the spine.
So that means with an incorrect curvature of the spine, we have an exaggerated lordosis problem.
Basic cause is if he is having a flexion contracture in the stump.
Yeah, if the muscles and abdominal muscles are also weak, then also he'll have the lordosis. The basic aim, I mean, what patient try to achieve with this movement is to keep his center of gravity to stabilize his body on the prosthesis. If he will not make this is compensatory movement. Basically, if he does not do this movement, he may have chances of falling, or he may have a fear of falling.
So if we are having a contracture and we don't accommodate that contracture in the system, So he wants to go in flexion, but the system doesn't allow him to go into flexion because he's having contracture. This will result in excessive lordosis of the spine. And second is the weakness, as we talked earlier, is weakness of the hip joint. As the hip joint is not able to control the system because it's weak, it results in excessive C-shaped curvature, that is lordosis of the spine. Weak abductor muscles. At the stance phase, the abductor muscles at the stump controls the processes into a stable phase and balance. But they are weak. To balance himself, he will result in excessive curvature of the spine.
So would you like to elaborate?
Yeah, and one more reason is the prosthetic alignment. When we align the prosthesis according to patient, and at the time of bench alignment, which we do in a prosthetic lab, if the socket, the interface is not aligned according to the patient's body, and if it is aligned in a extension, I mean the flexion of the socket is less, then that also causes lordosis of the spine.
That sums up regarding the gait deviation as far as stance femoral, that is above the knee patients, is concerned.
Okay.
Now we have is patients who have lost the limb from below the knee.
Okay.
They also have certain amount of gait deviations.
The knee is natural, but we are fitting the prosthesis below the knee. We are fitting the ankle part and the foot part of his body.
So the gait deviations that we discussed until now were the ones that had the problems above the knee, and now the ones which we'll discuss further will have the problems below the knee.
Yes,
Yeah.
the first major cause the knee is not fully extending.
Okay.
Means he has a knee, but it doesn't extend fully. So that means as he wants the heel strike, the foot to be there, it is not there. It is little behind. And the second one is excessive flexion. The knee is in excessive flexion, so he doesn't have the full extension. The second one is the instability at the knee, which causes because of the socket ill fitment, it can cause all this deviation. Then we have the pylon, which is not, it should be ideally vertical. It is not vertical. It is either medially shifted or laterally shifted. By changing the alignment, because he has his own knee, he has the knee power. So the deviations in below knee is very less.
In this case, the knee joint is natural, so the most of the gait cycle, it the control on the processes is maximum because he has a complete thigh section and the natural knee joint. And in this we observe several gait deviation, like body is moving laterally. When patient walks, body goes sideways on a prosthetic side. So that could be because of the foot. When we make a prosthesis, the foot is aligned medially. So the center of gravity and the base becomes very narrow, and because of that, at the time of mid stance on prosthetic side, the body goes on the lateral side, on the prosthetic side.
He is having insufficient knee flexion, or at the time of swing, the foot is dragging the ground and going. So that one reason is the foot is too much aligned in plantar flexion, it is not vertical. So as swing phase, which should clear the ground, it's not, so we align it, we dorsiflex it, and it becomes straight. Then again, prosthetic reason, we had the foot slap and the foot whip. The same reasons lies here, but instead of the femur muscles, now it is the tibia, the lower knee level muscles involved.
So basically the causes remain the same, but it's just that the upper limb, the limb above the knee or the limb below the knee, what is the one that's having a problem which causes the gait deviation?
Again, it could be a patient cause, it could be a socket cause, it could be alignment cause, or it could be the componentry used that cause. So we, by changing the bumpers, we get the good cushioning, and by aligning the processes, we get the proper alignment of the processes.
Okay.
That should be all. So as far
at
as
the time of heel strike, I mean, two main things, like when patient walks, there may be a hyperstability at the knee, or maybe the early knee flexion. That also we need to see whether the knee is properly adjusted and patient is walking normally.
Okay. So that means that was all for today. We discussed all about the gait deviations and the gait analysis in prosthetics. We discussed about the various cycles and the phases in gait. Then we discussed about the various kind of gait deviations which had the problems above the knee as well as below the knee, which included the foot slap, it included vaulting, included abduction, circumduction. Then we had the left trunk bending and various other deviations. We discussed their causes, how it can be corrected, and basically it's very important for the patient to have a high confidence level so as to work and walk as normally as he can, even with the prosthesis on him. So that was all for today. Thank you so much for joining us. I hope our viewers enjoyed our discussion today, and for any kind of feedback and suggestion, please call back on our toll-free numbers or on our phone numbers so that we can always live up to your expectations. Thank you so much for today joining us.
Thank you.